give a general overview, and then I was going to give a live demo. Yeah, when I do get into the live demo, I won't necessarily be able to see the chat or the hands. So Alex, if you could just keep an eye on that, and please shout. Feel free to interrupt me if there's a question that you think needs addressing urgently. So hopefully most of you are familiar with Model Health System, but I assume that the majority of you are more familiar with Model Hospital. So Model Health System is the expansion of Model Hospital to cover the STP ICS view as well as the provider view that has been shown before. So it's been a bit of a soft launch and obviously affected by COVID. But yeah, some of the compartments have been live for a good few months, but we're adding material and functionality all the time. So I'll start with a brief introduction of how you get into Model Health System and what it's generally trying to do, and then I'll go into some of the elements in a little bit more detail.
It's just joined us, so do you want to say a few words first? Hi, Jim.
Hi, Alex. No, it sounds like Bryn, we're doing a brilliant job, but I'm more than happy to jump in.
So yeah, Jim, I've just given a sort of general overview. I'm not sure if you want to share your slides or if you just want me to crack on with the demo.
No, well, my slides were just sort of a generic overview. I mean, who have we got on the call? What just analysts, or what are we in a particular region? Are we?
No, we're people across the country, really. So this has gone a bit bigger than we thought. So we started off as an induction meeting for the 4 analysts in my team. We've shared it with a few regional colleagues and some people at the CCGs who've got use of working with Rightcare and commissioning data. And then it's been shared with improvement leads across the region who are probably familiar with the Rightcare data, and also in other regions who had similar interests. So we've got quite a broad audience.
Cool, great stuff.
So in the chat what their interests are, that might help us as well. If you want to kind of say what
that's what I was going to say. If people can just sort of chuck ideas and then we can sort of direct it. I mean, Bryn was doing a great sort of update, sort of overview there. I joined the Model Hospital team about 3 years ago, sort of just after Lord Carter had published his report, and we started to build the Model Hospital from there, which was aimed as a benchmarking tool for productivity and efficiency. Looking at areas such as the clinical services, workforce, back office functions, support services such as pharmacy, diagnostics, imaging, those sort of things. But as time's gone on and we've sort of shifted directorates and things, then the productivity is still important. But I think we've kind of started to look at things like clinical quality through GERFT, and then Bryn and his team have joined. So now I think it's great because what we've got now is sort of the joined up pathway. Now I know there's still sort of data issues with that, but we've got the sort of population primary care as well as the secondary care, and sort of joining that together, we can start doing some really whizzy things. So yeah, that's sort of the background. And basically with the Model Hospital, it wasn't just hospitals. We included specialist trust, ambulance, mental health, community, but the aim was always as sort of following NHS England an improvement sort of strategy was to move towards STPs and trying to sort of aggregate that information. Again, we're still sort of mainly focused on secondary care because that's where the data is, but sort of moving towards trying to have a whole system view. And then over time, and Alex, we had a few sessions, I don't know when it was, I've lost track of time, probably a couple of years ago now actually, but we've lost the whole year with COVID, but looking at pathways and trying to use the Rightcare methodology in terms of the pathway on a page, ideal pathways, and therefore could we therefore match data across that and look at where patients followed an ideal pathway compared to where they didn't, and can we then attribute outcomes, workforce measures, cost, all those different things. Now we're nowhere near that at the moment. I think we've got a great combination of lots of different metrics, but I think it's still quite difficult to sort of move through that system. And the movement through that system could be in different ways. It could be the patient pathway, it could be the pathway of an individual person who runs a service, or it could be an analyst, all those sort of things. So we're trying to sort of work through that. And then additionally, as well as sort of new teams coming together, we've got additional products that have come together. So we've got the model health system, but then we've got a person called Medulla in our team who produces a lot of the Tableau dashboards. That are sort of a further drill down, more functionality than the model hospital, and therefore trying to investigate what can we do in terms of the whole ecosystem for people to go in through one product and then sort of be diverted to the relevant place to get the information, whether that's at a patient really granular level or a high level version. So yeah, I suppose that's my intro, Bryn. My slides weren't any different to that, really. I suppose the only other thing I was going to add was with the model health system, we've also tried to add in additional functionality through charting and things like that. So we've got SBCs in there now, although not fully utilised. We've got funnel plots within there that people can use, as well as the traditional histograms, trend charts and sort of bubble charts, things like that. I think we've also got confidence limit box plots coming soon. But yeah, that's kind of my intro.
So the questions I've got from the audience, we've got some CSU colleagues and system colleagues asking how do they make sense of this for system-wide and ICS level benchmarking, and how they use the data as part of an end-to-end patient pathway, which I think probably translates well to what you're going to tell us, Brent.
Yeah, hopefully we will certainly answer that last question. Jim, do you want to pick up the one about how it links with NHS benchmarking network?
Funny, I've just been in another presentation and exactly the same question came through. So in terms of NHS benchmarking, how are we using? So we utilise some of the data from NHS benchmarking, but we also have our own mechanisms to collect information. We try where possible to collect stuff from national data sets, but where data is not available, like around the corporate services and procurement and things like that, well, we've had to do our own data collection, try and pull that together. But yeah, we basically work with other providers like benchmarking, and where they've got additional feeds, we try not to go out and collect the same information. I'm sure there's bits of overlap, but yeah, that's how we try and work together. I think the additional bit that benchmarking give is that I know they run sort of facilitation of different areas, and they bring sort of multidisciplinary teams together, like clinicians, ops managers and stuff, and use the data like that, which our team doesn't do. Maybe wider improvement people do, but I suppose that's the distinction. I mean, ideally, we wouldn't pay for services. So even if you go to sort of Dr. Foster, HED, those sort of things, we're trying to provide a free service. It's our data. Let's push it back. And we've done stuff like an organisation used a specific metric, and they were paying for a benchmarking service and asked us to replicate it, and we did that. That was depth of coding stuff. So areas like that people are interested in, then we're happy to talk and try and sort of meet those needs.
Thanks, Jim. And there's another question there saying, has the sandbox tool now been added so people can develop bespoke reports?
Ooh, we're talking about the key thing. So it has. We're trying to break it ourselves in-house at the moment. And our head of development panicked when we said, oh, other analysts might be interested in this. But we can definitely work around the IG stuff to open that up. Yeah, so it's only just been developed, so let us have a play with it. And if there are specific needs that people want, so I mean, from my need, One of the things I wanted that I don't get from Model Hospital and the back end is sort of regional cuts and things. So in terms of having a cube or something like that, that we can cut the data in different ways. That was one of my specific needs. But if there are other needs from sort of back end data that people want and they can't get from the front end, pass it through to us. Probably through Alex is probably the easiest way. And then we can try and build that in. But yeah, once we've sort of agreed and we're happy with this cube that we're working with, then yeah, we can convince James to start sharing it out.
I think Joanne's got a hand up. Joanne, if you want to come in.
James, I was more thinking about, this was quite a long time ago, but we had some discussions about a tool that people could use to customize reports for themselves. So not necessarily the cube, but so that they could set up routine reports that they could run within their own organisations that would regularly report on whichever indicators they'd selected. And to sort of have a pick and mix approach to that. But it's been ages since we've had a conversation about it, so I didn't know whether it had been implemented.
It's not, but it's definitely still there. I think that the cube was sort of a hybrid to shut me up because I keep going on about it. So we can provide those sort of reports. But yeah, the idea would be, so we've got the bookmark functionality, but the next step from that, was to go say into a particular specialty and then theatres and then day cases and pick individual metrics and build your own report. So that's definitely still on the backlog of stuff to do, but it's not been developed yet. Sorry, Joanne.
Thanks.
Okay, so I think I'll get started with the demo, then I'll just share my screen. Okay, so as I said, I now won't be able to see the comments or hands up. Alex, if you or Jim could just shout and interrupt me at any point. So this is the Model Hospital login that most of you will be familiar with, and Model Health System is within the same platform. So if you click on the change organisation by the organisation name, then as previously you could select, as Jim mentioned, the ambulance trusts, community trusts or mental health trusts, but there's now a new STP/ICS system view. So I'll just pick the first Midlands one that I see, and when you do that, then you'll obviously see the colour change, and you'll then be in Model Health System. So the layout is obviously very similar to how that looks in Model Hospital and the other elements, but everything is now with this system view. So there's various different elements to this. We know obviously some people will just have a very specific interest and they'll want to go straight to perhaps the orthopedic surgery compartment or the urology compartment, but there's also a few sort of overall sort of landing pages, ways into viewing the data. So I was going to start by running through those and then get into some of the more detailed clinical service line compartments. So I'll start with the opportunities for improvement section. So this is very new, I think went live just before Christmas, so it's very much a work in progress, very much a first iteration. More content is going to be added, and there's also going to be a significant amount of tidying up and improving the content and making everything more consistent between the different opportunities. So you can click on that button just to expand that, but obviously you can see this button here for view all opportunities for improvement. So when you click that, it will take you through to hopefully without too much delay. I might turn my camera off just to speed things up. It's not normally this slow, so it's typical. As soon as you go to present, it goes wrong. There we go. So you can see a number of tiles for the different opportunities. So we've got a range of different opportunities. We've got day case rates, we've got length of stay, we've got readmission rates, outpatient attendances and did not attend. And from next week, we'll also be adding in some Rightcare population health tiles as well, which will look at admission rates on a population basis and looking at that variation to demographic peers.
Brent, just sorry to interrupt at this point. I'm not sure we're fully caught up with you in terms of your scrolling.
Right.
It's a little bit slow getting the screen, so we can see the 8 boxes with you on time lost to outpatients at the moment. But yeah, oh yes, caught up now. Just being a bit slow. Maybe my end.
Thanks, Alex. So yeah, you can, if I just scroll down, you can see that we've got about 20 opportunities in there, as say, covering a range of different things. And what you see in this tile is the headline. This is what the metric is, and then this is sort of set up around capacity. So yeah, what improvements, what potential opportunities are there to make improvements in terms of capacity? So either in bed days or beds. So for example, if I pick on this length of stay opportunity for cardiothoracic surgery, again, hopefully this won't be too slow. So for Birmingham and Solihull STP, then this is showing this potential opportunity of 7,000 bed days via reducing length of stay for cardiothoracic admissions. You can see that it's translated that to number of beds per year. And then if you click on that button, it takes you down to the section at the bottom, which says how this is calculated. So yeah, obviously a lower average length of stay is considered best practice. And then it's listing the conditions that this is built up from. Yeah, you can see in this table, then it's got a breakdown for all those different procedure groups, and you can see there they've got the system value and then the system median and the system top decile, and you know, you've got the chart there showing the average length of stay and this opportunity being calculated by moving towards that top decile. And as with the other indicators, you can view that on the interactive chart. So I'll go into some of the charting functionality a bit later in some of the other compartments. But yeah, as I say, this is intended as another way in for you to identify those potential opportunities, and then you can click through from any of these related metrics and they'll take you into the relevant clinical service line compartment, in this case the cardiothoracic surgery compartment and the GIRF clinical improvement sub-compartment within that. I'll just pause there, just check if anyone's got any questions.
We've got nothing on the chat. People, please raise your hands if you want to. I was going to ask, is this live yet, or is this something that's in the preview version? Because I can't see it.
Yeah, this is the live version. Yeah, so you should all be able to see this.
So I get highlighted metrics, but I don't get opportunities for improvement section.
All right, Jim, is that
screen. Just make sure I've got the right version.
Opportunities are only open to a few people, I think, at the moment.
Right, okay.
So
we launched it just before Christmas and opened up to a few people. So we're just tweaking some of the metadata and bits and bobs like that. But yeah, it will be. I think in the next couple of weeks, I think we're going to do a joint launch with the new Plix data.
Thank you, Jim. It's useful to know. A couple of questions on the recency of the data. I'm sure you'll get to that when you show some of the examples. It sounds like other colleagues also can't see the STP improvement opportunity. So yeah, access to that will be appreciated. So Brennan, I'll just hijacked your screen, so you might share again.
Yeah, no, it's fine. So yeah, in terms, so all of those metrics are at a slightly different time period, yeah, depending on whether that's part of the annual refresh or quarterly update. So we've also got a COVID recovery compartment, which has got the faster source data in there, and then yeah, within some of the Rightcare content, we've got rolling monthly updates as well. So yeah, each metric is different. So some of it is a bit more dated, and as Jim's just mentioned, we've got the big annual refresh coming on stream in the next 2 or 3 weeks. Okay. So just reading that question that's just popped in there. Sorry. So does the data include any out of county activity? So it depends on the indicator that you're viewing. So this indicator here is built up from the providers that sit within the STP. For some of the other indicators that are built up from CCG level, then that's on the registered patient basis. And yeah, for some of those indicators that are available at both commissioner and provider levels, so for example RTT, where it's published on both, then yeah, we will probably be including both views, and with a relevant drill down. There's probably still some sort of user experience work we need to do about sort of understanding the way people would like to flow through the data and how we present that. But yeah, at the moment we do have those 2 different ways of pulling this up to the system level. Okay. So yeah, sorry, bear with me. I'll just return to the screen. So yeah, opportunities for improvement. That section is very new, and obviously, yeah, not only currently viewable to ambassadors, as Jim said. So, but that will be coming short, and we'll be having more content added in due course. And then Alex mentioned the highlighted metrics. So again, you can expand.
So, can you share your screen, Brent?
Oh, sorry, have I?
Cheers. Thank you.
Not gone back to sharing. Apologies. Okay, yeah. So sorry, just underneath the opportunities for improvement, we've got the highlighted metrics section, and yeah, again, you can see a range of tiles within this, and then the opportunity to click through to view all highlighted metrics. So again, in a similar way to the opportunities, this is just trying to highlight some of the areas that might be most important for you in a system to view, and these are indicators which have been RAG rated, and where your system is coming out as having an opportunity to improve in yeah, I mean, each one is set up differently. So yeah, for example, this example here, looking at the average proportion of beds occupied with long stay patients. So there's a wide range of different indicators, and these are just sitting within the relevant compartments. So this one's from the urgent and emergency care compartment. So it's just another way to highlight some of those indicators that might be more important for you to view as a system. And then, yeah, once you've clicked into it, it's just the usual way that you would view the information. And I'll come on to the chart functionality in a bit more detail in a moment or two. But obviously, what we've got here is the STPs in this chart, as opposed to the normal functionality that you'd be used to from model hospital, which would have the trust view. So yeah, you can see the full distribution for those STPs, and then you can also, there's a few toggles here. You can toggle between the chart view and the table view. You can toggle between the system view and the trust view. And just go back to this one. You can also have the systems within the Midlands or all systems nationally. And you will also see that on this main chart that some of these STPs are highlighted. So there's two different options for highlighting the peers here. So one is within region, so you know, obviously just the other STPs within the region, and the other option is a similar STP functionality, which is based on a range of demographic factors such as deprivation, ethnicity, age profile, rurality, etc. And that's based on a very similar approach as to the similar 10 CCGs that are used in the Rightcare content. So yeah, again, I think I'll just pause there and see if anyone has any questions on that.
So we've had a few questions about the availability of children's data on there, and some questions around what we might want to cover. So I think we'll get to that as we go down the sections about what is available. The questions about what's included. So I think some of these indicators are provider based. So it's provided to STP mapping directly. So it's all activity for that provider. But some of the data that Bryn's going to show in a moment covers the population based. And Ian Ellis, one of our co-founders, has asked that question. And Roy's asked about SPC charts. So it'd be useful to see the example of what we can and can't do with that. I think that's something still in development, Roy, that was mentioned earlier. But yeah, we might get to that one at the end if we've got time.
Great, thank you very much, Alex. So yeah, I'll just continue carrying on down through the sections. So we've then got a board level oversight section. You can see here within here we've got a referral to treatment. I'll just quickly go into that, but I won't dwell on it in any particular length of time. But for example, here you can click on to see the 18 weeks performance. So you can see that yeah, we've got the percentage here for each of the specialties. So you can take that view across the whole piece and see that yes, obviously the for this STP that trauma and orthopedics has obviously got a RAG rating of green there with a system value of 10.22% compared to the median of 13.29, whereas ear, nose and throat have got almost 12% of patients waiting more than 18 weeks compared to the peer median of 10%. So, and yeah, I mentioned some of the chart functionality previously. I think this is probably a good one to demonstrate that. So if you go into the interactive chart, then you can, sorry, no, that wasn't a good example. I'll come back to that example.
Brent, go to the bad stay case opportunities. It's in there.
Great.
I've just done a presentation and
good, thank you. So that was my next port of call, actually, so that's convenient. So yeah, I'll just go into that one. So yeah, again, obviously, I think you'll be fairly familiar with this compartment. So yeah, obviously, as the overview says, compare the proportion of day cases. So we've got the organizational level overview, and then we've got that breakdown by specialty. So if I click into the breast surgery rates, again, go to the interactive chart.
I think it's in the opportunities, mate. I don't think it's in that one. I think if you go to the overall opportunities as an example.
You mean on the opportunities page?
Yeah. I think a few of the toggles have been turned off, but that one top left should work for SPCs and funnels.
Great. So yeah, we've got a tree map here, but I won't dwell on this. This is one of the areas that's being tidied up, but yeah, just breaking that opportunity down by the different specialties. Is this the right one, Jim?
I'll put the link, mate. It's in the preview site. You might need to log into preview. I can share if you want.
Yeah, if you can just switch to your screen, Jim, that'd be helpful.
Cool. 1 second. Can everyone see that?
Yep, that's fine.
So as per normal, when you could change the different chart types, we've now got these two here. SPC, which has some of the rules. It doesn't have where you can actually change the limits based on, so if you wanted to recalculate the limits, say here, we haven't got that functionality yet, but that's coming. But you can see you've got the different rules here, and then we've also got funnel plots as well, which you can calculate.
That's really useful. I've got like funnel plots.
Back to you, Brent.
Useful to see what's coming in the preview version, even if I can't quite access it yet.
We can arrange, Alex, if you want preview access.
I think we've got 70 people on this call that I want to.
Yeah, shit, forgot about that. Yeah, but we can arrange for a few people if they want it.
Yeah, if people are asking, we'll send you a list of willing victims to test it, and hopefully get it rolled out further as soon as we can. So, Brent, back to you.
Great, thank you. And then so next within the care setting section. So yeah, as a briefly. Oh, sorry. Sorry about that brief technical issue there. So yeah, we've got the day case rates. So within this overview, when it loads, we'll have the overall British Association of Day Case Surgery Procedures basket. So yeah, you can see that this system is performing at 58% compared to the regional peer median of 71% and the national median of 74%. And then further down, you've got the day case rates for within the particular specialties, and then we've got, if you click on that, we've got indented metrics for both the numerator and the denominator. So again, this is a sort of useful, you can use the spine chart to view those where within a system, those specialties where the system is doing better and where the system is doing worse. For this system, there seems to be quite a lot of red there. Obviously, ophthalmology and vascular surgery, where they're doing better than the peer median. Again, that one's probably quite straightforward, but again, I'll just pause to see if there's any questions on that.
Not yet. Anyone else to jump in? Feel free.
Okay. And then similarly, we've got inpatients, which you'll be fairly familiar with as well from Model Hospital. So yeah, we've got the general inpatient metrics. So yeah, covering length of stay, short stay admissions, and then down at the bottom, we've got the daily discharge ratios as well. So again, all the same functionality really, and the same set of metrics that you'll probably be familiar with from the Model Hospital platform. And then yeah, just to show you a bit more of the information that you can get that broken down by age there, and then we've got the percentage change year on year as well. There was, and then if I just go back to the inpatients landing page, then again we've got the specialties, so you can click into each of those and view the metrics at specialty level, and then we've also got a series of headline metric tiles within here. So yeah, different, showing some of the key metrics from within this compartment. So you can just click into any of these. So for example, this one being the percentage of emergency admissions with a length of stay of 0 or 1 day. And again, you can go to the interactive chart. So again, yeah, you can see there that variation between the STPs, so ranging from 44% in Lincolnshire to 62% in Buckinghamshire. And again, you can just show some of that charting functionality. You can view that trend line chart. So yeah, within here we've got the system, the national median, and then the regional peers. And as I say, you can alter that to be looking at the demographic peers as well, and that's just done via this peer group button here, which if you click on that, is that something that's not gone live yet either, Jim, the STP peers, or is that?
It's there. Yeah, it's not live, it's in preview, but it's there.
Right.
And it's just been updated. So Sadia and Holly have just sent me actually an updated list based on the new data they've got. So it's a similar algorithm to the model hospital peers, but more sort of population based.
Great, thanks, Jim. And then, yeah, again, I won't dwell on any of these compartments in too much detail, but worth highlighting the theatres compartment as well. So we've got indicators on the theatre utilisation. So yeah, including the touch time utilisation, the average number of cases per session, and yeah, some of further indicators there on late start and other indicators. So again, I won't dwell on this element, but happy to take any questions that anyone has. Okay. And then I think the next one I'll move to is the population health department. Again, this is very much a work in progress, and we've just got the inpatient data in here at the moment, although the primary care prescribing data will be added shortly, and then we'll also be adding in outpatients, A&E, and a range of other data sources as well. And one of the things that we're doing at the moment is just working up options for how we're going to structure this. So at the moment, we've just got this structured by the programme categories that we've covered in the Rightcare packs, but we're also working up a structure based around the care settings, so flowing through from prevention and primary care and A&E, ambulance, outpatients, through to secondary care, specialised commissioning, etc. So yeah, it's very much a work in progress, but I'll give you a quick run through what we've got included here. So we've got a series of headline tiles here, headline indicator tiles. So we've got those tiles for the main programs, and we've focused on the total bed day rate here, and we've got a couple of different presentations. So what we've done here, so effectively COVID is causing a big problem for how we would normally present the data, because we would normally compare, show systems comparisons to their demographic peers. So for example, in this case, the number of, or the rate of bed days per 100,000 population for cancer and tumours. However, those demographic peers are spread all across England, and obviously COVID has had a very different impact in different parts of the country. So what we've done to try and ensure a fairer comparison and try and just avoid showing variation in admissions that have been driven by the extent to which different parts of the country are being hit by COVID, we've used 2019 calendar year as the baseline measure, and then we've got an updated monthly indicator showing recovery from COVID. So very much intending that these two indicators are viewed alongside each other. So I'll just click into this indicator. So what we've got here is an aggregation of the difference in bed day rates that the constituent CCGs have to their demographic peers. So over on the right-hand side, we've got North London Partners in Care, Health and Care, STP. So this takes their constituent CCGs, there as an age, sex, standardised rate of admissions per 100,000 population, and then compares that to their 10 most demographically similar CCGs. And then the difference in that rate, whether positive or negative, is aggregated up. And this is coming out as a rate of 1,034 per 100,000 population. So essentially, they're doing a much higher, or they have a much higher rate of bed days for cancer and tumours compared to their demographically similar peers. And then down at the other end, we've got Cambridgeshire and Peterborough, who have got a much lower rate of bed days for cancer and tumours in that time period. I'll just flip back to the other indicator. Oh, sorry. And then, alongside that indicator, we have got the COVID recovery indicator. So this is showing the percentage of activity in the last 3 months compared to the same 3-month period in 2019. So for this STP, which was Birmingham and Solihull, I believe, they are currently operating at 78.5% of the amount of beds that are full for cancer patients compared to that same period in 2019. And then you can see there the regional median and the national median are a fairly similar level. Again, if I go into the interactive chart, you can see how this has changed over time. So this is a 3-month rolling indicator. So we've got data from April to June all the way through to September to November. And you can see a fairly similar picture that this STP has to both the regional and the national, that the recovery very much took off, so moving from 55% up towards 85% of activity or bed days being recovered, but then has started to tail off again in that last from sort of November, and I imagine that has only got worse. We'll be adding the October to December data in next week. You can also view this in the variation chart format as well. So again, for Birmingham and Solihull, you can see that that's slightly lower ratio of bed days compared to both the regional and the national median. And then you can see the outliers at either side of that as well. But as I say, very much intended to be looked at alongside the main baseline indicator. So East London Health and Care Partnership have done very well at turning the activity back on for cancer and tumours, but they would obviously need to consider that alongside their rate, their baseline rate for 2019 calendar year, and consider whether that is something that needs to be increased or reduced. There's a few more elements that I'd like to show, but I'll just pause there and take any questions.
We've had a couple. Nigat, you've asked questions around the case mix, how we've adjusted for that, tertiary centres and settings. So I think I've understood this correctly. This is more similar to the Rightcare method, where we're doing a simultaneous comparison and age sex standardisation for the population.
Yeah, that's right. Apologies, should have made that clearer. So yes, this is based on the registered population. So each patient is assigned to a CCG on the basis of the GP practice that they're registered with.
Does that answer your question, Nigel, or is there something more nuanced about the case mix you wanted to know? Do you want to?
Yes, thank you. I guess it was looking at the cancer work that we're doing through Starboard. We know that tertiary centres, their length of stay and their pathways are different when you start to look at the 28-day pathways. And I just think, how do you factor some of that in? Because it's we might be penalising some providers more than others if we look at it from this way. Is there a way to adjust it to accommodate that?
So it should account for that in my thought, because it's population based, so it should be wherever the patient's treated.
So it should accommodate it.
Setting. But you do sometimes see biases, don't you, when you have people use their local settings in a different split. So it's probably to compare between the two provider settings. You can look at change organisations to view the different providers.
So will it show if where you've got tertiary centres, there's a theory that actually you get faster, slicker treatment into and staging? Will this data sort of highlight some of those geographical health inequalities? Could you use it to show that?
Yeah, so I'll come on to the cancer compartment in a moment, but yeah, we do have that staging data in there. We're trying to, as Jim mentioned earlier, trying to present everything sort of in a pathway basis. I mean, it's still, again, as with everything on model health system, it's still very much a first cut, and we'll be trying to bring in a bit more of the provider view into that as well. But yeah, in terms of the original question, so yeah, if there's a big tertiary centre within your STP, what's captured in these indicators is not all of that activity, just the activity for patients registered with a GP. However, there probably is an element of not supplier-induced demand, but there probably is an element that yeah, access to those is affected by proximity. So I think if you're if patients are a long way from the tertiary centre, then there may well be an access issue. But yeah, as Alex said, sort of this does at least strip out the direct effect of that, if not that indirect effect.
Thank you. That's helpful. Thank you very much.
There are a couple of other questions about access in this section. I can see the STP version. So when I pick STP, I can see the population health section, but I don't think everybody has quite got that. So it's probably worth just checking if you can, and probably email model hospital support if you can't, just to check you've got the right settings.
There shouldn't be any limitations, Alex. It's compartments that we tend to lock down, not the actual site. So if you top right select an STP, then you should get that version. If not, then let us know. But yeah, it's more to do with the organisation type you pick rather than the compartment.
Thanks, John. And that's it, I think.
Great. So yeah, I just wanted to touch on another couple of elements. So yeah, for Birmingham and Solihull, we saw that in terms of cancer and tumours for their baseline period of 2019, we can see that they're on the lower end, so they do have much lower bed days for cancer compared to similar peers. And as I say, I'll come on to the cancer compartment in a moment and show some of the other pathway information that might want to be used to triangulate to see whether that's what would be expected or whether that's something to explore further. We also, so that rate there of -788, so that's the value per 100,000 population. We've got an indented metric there that just expresses that in the number of bed days. So if every CCG within the STP was actually had an average rate, a rate at the average of their demographic peers, then that would be an extra 9,000 bed days per year for cancer for this STP. So yeah, they've currently got 9,000 bed days worth of fewer patients for cancer within the system, and yeah, that's the overall bed days. We've also got that indicator in terms of number of admissions and the spend, or the tariff weighted activity. As you'd expect, those three usually very much aligned, and we've got negative values for each of those. But again, you can just see that that's coming up to £6 million less spent on cancer, and that's not including the specialised commissioning elements. That's just the mandatory tariff activity, and that also equates to 2,688 patients. So yeah, we present that data in those three different ways, and then we also break that down for elective and non-elective. And as mentioned earlier, we obviously RAG rate the non-elective metrics. So again, I'll just pause there just to see if anyone's got any questions on that.
No questions, but I'm just going to clarify that, yeah, people that understand this from a Rightcare perspective, seeing negative opportunities might be a bit confusing. That's because this is areas that are underperforming the similar tend to have less activity, or fewer admissions, or lower spend potentially. So it's normally what we put at 0 on a Rightcare chart as an opportunity. We're showing with the negative value, so it all kind of shows the full story. And I think it's, am I right saying it's a similar 10, not the best 5 that we compared to?
Yeah, that's right, Alex. And then in the opportunities section that will be forthcoming shortly, we will present the range. So for those bed days, for example, we'll be presenting that as a range from the similar 10 average compared to the lowest 5 within those of those similar CCGs.
Hannah's just asked a great question, actually. Is less activity for cancer good? Which I think you're going to show something about colour schemes.
Yeah, absolutely. So I'll come on to the cancer compartment in a moment. But yeah, so what I mean, across all the conditions, not just cancer, but we don't RAG rate the overall activity. So for the total admissions, bed day spend, and the elective activity, then we don't make that judgment call. So for Birmingham and Solihull, they're spending almost £6 million less on cancer. We don't make a judgment call on whether that is a good or a bad thing. We encourage looking across the whole pathway, looking at the prevalence, looking at the primary care, looking at mortality rates, and trying to triangulating across everything to see, is that what would be expected, or should you be looking to try and increase the admissions spend, staging data that we discussed, get people earlier and deliver better outcomes. And then in some areas, yes, you might be looking to reduce the overall levels of activity. However, yeah, as mentioned, the only area that we RAG rate is non-elective. So yeah, the assumption being that it would be better to be picking patients up earlier and treating them as elective rather than non-elective. So yeah, we do RAG rate that non-elective, but again, it would be, yeah, we'd always advise looking at that alongside the elective data. If you've got very low elective activity and very high non-elective activity, that might reflect that the pathway isn't working well and you're not picking patients up, but that might just reflect, you know, a particular way that the system deals with people, whether to so yeah, we wouldn't ever say that something is definitely a bad thing. Okay, I think
one other question on that was around the comparing how does it fare with COVID recovery. And I think you said that it's 2019 data for the main benchmark, so it's all pre-COVID, and then we've got a separate percentage recovery indicator. So I think that splits it out. Does that answer your question? Yeah, that's okay.
Sort of. It was just I was trying to understand if just in like with the previous question is lower activity good or bad? Are we able to benchmark it with previous activity or prevalence? Is that any way of doing that?
This is going to be really difficult for us all, I think, in the coming years, knowing whether we can trust the data given anything that's changed. We might have had population differences. Yeah, it's going to be an awkward one. Bryn, I don't think I have on that from your team, but I think what I'm planning to do is use 18-19 or 2019 calendar year, try and have a robust pre-COVID period to give us a baseline position, and try and interpret that in a post kind of COVID way and look at the recovery. So it's interesting, but yes, there's other changes going on in terms of block contracting and everything else that might make things a bit more interesting going forward. So it's going to be a really difficult time for the benchmarking industry. Bryn, I don't know if you want to say anything else on that.
Thanks.
Well, not necessarily directly related, but we have had discussions within the team about whether we should be rag rating those recovery metrics, which we haven't done so far. But well, as I've been talking through it, you'll have realised that I've got an implicit assumption that higher is good, and that you want to be doing as much activity as you can to try and recover. But we haven't rag rated that so far, and again, just because different parts of the country are very differently hit by COVID. So yeah, it would. I mean, it would be good to get views, but we haven't done that so far. In case an area that's particularly badly hit by COVID would be being rag rated, they may not find that helpful, because they may well know that they've not done as much cancer or musculoskeletal activity as they would like to, but they've just got too much of a COVID problem. So yeah, it is very much, as I've said, sort of trying to triangulate across the various indicators. But yeah, if anyone does have a view on that issue, then yeah, we're very happy to hear that. Okay, so I'll now move on to some of the clinical service line compartments, and yeah, I'll start with cancer, seeing as that's the area that we've just been looking at, and quite a bit of interest in that by the sounds of things. So yeah, again, if you keep scrolling down, you can get to the clinical service lines section. You'll notice the first one there being cancer brackets Rightcare. Generally speaking, we're merging all of the compartments so that we've well, you'll see for all the others, we've just got gynecology, urology, ophthalmology, and those contain the Rightcare information. They contain the GIRFT information, the standard model hospital indicators that we've been through on day case rates, length of stay, theatres, RTT, etc. So yeah, however, with cancer there is a separate dashboard. I think this links to what Jim mentioned about some of the other sort of Tableau and sort of tying this all into one platform. So yeah, a lot of the sort of provider level data I think is already picked up in that dashboard. So at the moment, this cancer compartment is sort of solely based on the Rightcare. So I was just distracted. I think is there another question there that's come in, Alex, that I might want to answer before I go into cancer?
Yeah,
I'll just type in the answer to it. So is that the one from Jessica in terms of the peers?
Yeah.
Yeah, cool. So we've got a number of different peer algorithms. So one we developed before Bryn and my teams came together. So we had that for the actual hospital providers, that we created an algorithm based on loads of different factors. We did Euclidean distances, and then we used an AI algorithm over the top to do the weighting. So we've got that one. And then in terms of the systems, we've had a couple of people who developed that in my team, and then a couple of people in Bryn's team who developed the Rightcare peers who have come together. So we've got that now. I thought it was in there, but I've just checked actually based on your question. It's not, but it's there. But I have just had an update from Holly and Bryn's team, who have just updated the latest data. So we'll push that out soon. And then the other methodology we've got and we're working on is a specialty level one. So you could say Derby Hospital's urology department, who are the top 10 closest urology departments based on that. And again, similar methodology that we'll push out, but happy to share that. Yeah, and get feedback. So yeah, thanks.
Great, thank you very much, Jim. Okay, so yeah, I'll go into the cancer compartment then. So again, you'll see on the left-hand side we've got the various subcompartments for the different types of cancer, and then we've got a number of key metrics, headline indicator tiles that we've selected here. So some of the cancer detection stage information that was asked about, we've got that for breast, lung and colorectal cancer. Again, you can click through into any of these so and see, yeah, so the system value being 28% and the national median being 28%. So this STP very much average in terms of that indicator. Just go back, and then yeah, we've got the urgent referral data, and you can see, yeah, we've obviously got that as a time series. We've got the patients with an urgent GP referral for suspected cancer seen. There's an obvious big drop-off there that happened in March 2020, which I'm sure you can all work out the reason for. And then obviously, yeah, we can see that that recovery started to happen there. Again, I'll just go back to that compartment. Yeah, we've got the percentage of patients receiving the first treatment within 31 days. We've got, yeah, this within 62 days. Then we've got some of the outpatient attendance, again, the difference in activity rate and the percentage of attendances that are new. And then similarly, we've got that COVID recovery time series for outpatient activity as well, for both medical and clinical oncology. And then we've got the cancer mortality information as well. So again, I can click through to this one. So yeah, this is the directly age standardized rate of mortality for cancer for under 75 people aged under 75. And yeah, again, you can click into this. And so again, just to reiterate that this is built up from the CCG level compared to its similar demographic peers. So yeah, sort of linking to the question that we've just had on the peers. Yeah, obviously we wouldn't compare the cancer mortality rates from STP to STP directly, because obviously there's a huge differences in deprivation and other factors that will impact upon cancer mortality. So all of these comparisons are shown as the difference in mortality compared to those similar 10 CCGs. So yeah, again, you can see there that Birmingham and Solihull, so they've got yeah, a better mortality rate compared to similar peers, and you can see there that some of the other STPs within the region have actually got much higher mortality rates.
Bryn,
yeah.
Can I just nick the screen out? I can just show you in the preview that the recommended ones. Hold on.
Yeah, sure.
So I'm in preview here, but we've got region. You can also select and then recommended. So I'm in Kent and Medway. So they're the recommended. For the providers, we had 10 recommended, but when we did 10, it pretty much chose a whole chunk of STP, so we limited it to 5, but we can change that. But yeah, just to show that functionality. Cool, back to you, mate.
Thank you, Jim. Okay, so sorry, it's been a bit slow again. And yeah, for that cancer mortality, again, you can, we've got an indented metric there that will show that, what that actually means in terms of lives, which I will go to. So yeah, we saw that Birmingham and Solihull had a better rate compared to the similar peers. So that's effectively saying that they are, yes, saving 36 lives a year compared to their demographic peers on cancer. We've also got the end of life indicator there, the percentage of all cancer deaths in usual place of residence, and you can see there that Birmingham and Solihull is at 37.4% there compared to the national median of 45.4, and again there we can see that difference expressed in the number of people. So if they move to the average, then that would be an extra 175 patients who would die in at home or their usual place of residence. I'll just go back up to the top. I won't go through this in a huge amount of detail given sort of time constraints, but as mentioned earlier, we've got the section for prevalence and detection. We've got a section for waiting times. We've got a section for outpatients, and then the inpatient data that you've already seen, the patient experience from the cancer survey, and then that mortality section. For probably a more complete view, if you look at some of the specific types of cancer, because certainly some of that information is only collected for breast or lung or colorectal. So for example, yeah, if you select breast cancer, then you get a wider set of indicators. We've got the cancer screening data, we've got the stage of detection, we've got, yes, more indicators from the cancer incidence as well. But then we also bring through some of the overall cancer survey data. So yeah, the percentage of patients who saw a GP either once or twice before being told to go to hospital, that indicator isn't specific to breast cancer, but we've pulled that through, so as we think it's a useful indicator. Yeah, again, I won't dwell on this for too long, but yeah, just to sort of reiterate what I said previously, that we've got, yeah, a lot of information sort of at many stages of the pathway, and yeah, very much encourage users to sort of view all of this together. So to sort of loop back to the question earlier about is low spend on cancer a good thing? Well, that would very much depend on the prevalence rate. So we've got the cancer incidence here. So Birmingham and Solihull is got a much lower rate of breast cancer incidence. So we would probably expect them to have slightly lower spend. But you'd want to consider that alongside the screening and the stage of detection and the referrals and the waiting times and everything. Again, I'll just pause there, see if there's any questions on that.
The chat seems to have gone into the challenges of ESR data and workforce and how it can break that down by speciality. So I think we can crack on.
Okay, well, Jim, I can see you've replied. Is there anything else you want to say on the workforce data?
No, help us improve the quality of it. I mean, one of the main reasons we actually started to publish ESR data was to try and improve the quality of it, and we were advised against it. I think we've made some inroads, but it's a difficult one. I suppose that's all I have to say on it. But any advice or any metrics that we could do to sort of support either improving quality or any advice would be good. Thank you.
Great, thanks, Jim. So one thing that I've just thought that I should have said earlier is that not all of these indicators are the difference compared to the similar CCGs. Where we don't think factors such as deprivation should be having an impact, then we've just used the STP aggregate. So, for example, this waiting times indicator, people who have seen within 2 weeks of an urgent referral, this is just a straight aggregate of the values, so summing up the numerators and the denominators to come up with an STP percentage. So our rationale being that regardless of how deprived you are or how many breast cancer patients you are, you would still want to be seeing people within that 2-week target. So that's sort of what's driving that benchmarking and that RAG rating. Just thought I'd make that point clear, which I should have done.
Make that clear in the definition below.
I'll let you be the judge of clear. So we've in the understand the data section, we specify here that this is calculated by dividing the aggregate of the numerators and the denominators, and then we've got further information in the methodology as well. Sort of feedback, very, very much welcome in terms of whether this is as clear. I mean, it's possibly the other indicator that we might want to see, but this is a straight percentage here that you're seeing, so it's not a difference that the Birmingham and Solihull is seeing just under 60% of all its patients, all its breast cancer urgent referrals within 2 weeks, whereas the benchmark value here is the national target, and then obviously we've got the peer median in there as well. Certainly any feedback very much welcome. As I say, this is all very very new and very much a work in progress. So certainly very happy to get any feedback and to help us improve it. Okay, so I'll just give you a quick run through some of the other compartments then, and particularly some of the alignment work with GIRFT. So I'll choose ophthalmology. so which is one of the areas where we actually aren't as well aligned. So I think that might be more helpful than showing you one where we've just got the same set of codes and indicators. So yeah, we've been doing a lot of work with the GIRF program, sharing codes, sharing indicators, trying to align where we can do it, unless there's a sort of good clinical reason why we'd want to be showing something different. So yeah, this is a newly merged compartment. So we've got the Rightcare data and the GIRF data within the same compartment, and these headline indicator tiles are a combination of the Rightcare and the GIRF metrics and the standard day case inpatient theatres metrics that I've been through at the start. So yeah, I'll just show some of the information that we've got within the GIRF compartment. So yeah, based on the GIRF National Report for Ophthalmology, you can see here we've got information on cataracts, corneal graft, glaucoma, trabeculectomy, vitrectomy. I'll stop. There's no more before I get into trouble with my pronunciations. And yeah, again, probably most of you are familiar with the GIRF data, but we've got the day case rates, the emergency readmissions, return admissions. So the presentation style all very much similar to what you've seen. But yeah, we've obviously got that sort of more detailed information. So it's very similar to sort of the day case rate information and length of stay within these compartments, but drilling down to a more granular level focused on these particular procedure codes. And then alongside that, we've got the Rightcare information. So for example, if I go to inpatient procedures, so from the GIRF section, you'll be able to see how we're doing on day case rates for cataracts, and I didn't actually clock what it was for Birmingham and Solihull, but yeah, they may be doing very well on day case rates, or they might have an opportunity to improve on that, but they could also, alongside that, view the rate of admissions and rate of those procedures. So again, sort of similar here. This there's an indented metric. So compared to the peers, Birmingham and Solihull is doing an extra 5, or was in 2019 doing an extra 552 cataract surgery, simple cataract surgeries compared to the average of their similar peers. And again, that's directly adjusting for the age and sex of the population. And then we've also got the COVID recovery indicator there as well. So at September to November 2020, they were doing 72% of the number that they were doing in those same 3 months in the previous year. We've also got that broken down by condition as well. So yeah, we've got by primary diagnosis here, we've got the information on glaucoma and disorders of lens and the various others. So again, all in the same format, but just breaking that down by the diagnosis group rather than the condition group. And I mentioned that this is one of the areas where we weren't as aligned. So just as an example of that, within the GIRF data here, we've got in the glaucoma section, we've got the day case rate for glaucoma tube surgery. whereas within the Rightcare, then we've got all glaucoma admissions, and tube surgery is, I think off the top of my head, roughly a third of all the glaucoma admissions. So yeah, there's another sort of whole set of procedures that would be captured in the Rightcare data. So yeah, we're working very closely with the GIRFT program to try and align in terms of the codes we use. And as I say, when there is a difference, we just need to make that as clear as possible. Again, there will be some differences in terms of how this, well, there are some differences. So this is aggregated up from provider level to be the STP value, whereas, as mentioned previously, the Rightcare data is based on the registered, where the GP practice that the patient is registered at. So again, yeah, I think I'll pause there, see if there's any questions on any of that so far. I'll take silence as no, and then just to highlight another bit. That indicator that I was going to, so that section that I was going to highlight is only available to view for a number of systems that have actually filled in that GIRFT questionnaire. But yeah, there's just to highlight that GIRFT did send out a questionnaire, and providers, it was obviously voluntary, but for those providers that did fill that in, then we've got that information within that subcompartment as well. Okay, so there's quite a few other compartments, but I think I'll just sort of pause there and check. Yeah, I'm quite happy to continue running through the different compartments, but the sort of format, layout, sort of structure is all going to be very similar. So yeah, just sort of pause there and see if you'd like me to continue, or whether we'd like to sort of anything else you'd like to see, like us to cover.
Nick asked a really good question about how do we start interpreting this, because it is quite an overwhelming amount of detail when you drill down into it. I think we've got the improvement metrics at the top and the areas to focus on, but is there a kind of a middle point for that, for say ophthalmology, to kind of show us on the page where you'd start, and what would be your way of working through this to give you the steer on where to focus?
Yes, I think there's a few different ways in, and as I say, some of them are very much in development. So we've got the opthal, so we've got the opportunities section and those headline metrics. So that's sort of one way to go into specific areas. We've also got the population health compartment, which, as I say, we are sort of planning to restructure that, so you'd be able to sort of look by care setting and say, are we high on A&E attendances, ambulance journeys, outpatient attendances, elective, non-elective. So looking across the system and seeing sort of where the pressures are, and then from that drilling down to the particular specialties or diagnosis groups that might be driving that. And then, yeah, sort of within the sort of specific compartments, then in terms of sort of one-page view, well, we've got this headline indicator sort of set of tiles, which hopefully sort of presents the key information. But as I mentioned earlier, we're also planning to move towards a more of a pathway view. So we'll be introducing a new set of subcompartments to cover those pathways. So, for example, within ophthalmology, we'll probably be introducing pathways for cataract and glaucoma and medical retina. And then, yeah, the intention is that we'll pull together the sort of key metrics across the pathway, including Rightcare and GIRFT and outpatient. And then we can, so similar to sort of the pathway in a page approach that we've got within the within the Rightcare packs, but yeah, very much bringing in that GIRFT and secondary care acute data as well. Does that answer the question, Nigat? Alex, is that any other sort of follow-ups?
I think it does. I think there's some other questions on more around that extra data coming online. So yeah, and one point to make clear is this doesn't completely replace what we've already got in terms of Rightcare packs and fingertips and all the other different data sources you can probably use alongside this one. So it's not aiming to dominate everything, but the one source for everything, I don't think. But yeah, there are other places you can look for some of this data if it's not quite in here. We'll get in touch with in our region if you need help.
I agree with that, Alex, and yeah, I think Brim will as well. We've come together as teams and sort of trying to, know how well received the Rightcare packs were, and trying to put it into a system that probably wasn't built for this. So, trying to sort of get to the best usage for, well, the best usability for people using this sort of data. So really open to sort of any ideas and, how we can sort of better do this. And in terms of, I mentioned earlier about the pathway stuff, I don't know if Roy's still on the call, but we did a bit of work with Roy in the Midlands region to sort of try and sort of sketch out some of the pathway stuff. Yeah,
still needed, Jimmy, absolutely. Still on the line and still needed as well. Systems are really, really keen on that sort of approach. I know, as we are too.
Yeah,
absolutely.
Yeah, thanks. We'll get there.
Yes.
Apologies.
So yeah, I was just going to say. So I think we've taken the sort of first baby step towards that by bringing this in, and then it's sort of merging this together in the sort of the best way for users. And yeah, I can see the comment there from Jessica that this is still very much secondary care based. So yeah, I mean it is without doubt, and that's sort of largely because that's where the most data and sort of certainly most rapidly available and sort of comprehensive data is within secondary care, but we're going to be bringing in a wide range of other data sources as well. So obviously I've touched on some of that within the cancer compartment, but we'll also be bringing in the QoF data from primary care shortly. In terms of community care, I mean, Jim's mentioned that's going to be brought in, but we're also doing a piece of work across 3 clinical areas at the moment to try and sort of bring all of this together into a pathway. So for musculoskeletal and cardiac and ophthalmology, there's a lot of work going on in those areas. And so, for example, within MSK, there's 5 pathways that are being looked at as part of that work, and we'll be developing metrics as to sort of align with those pathways. And the community data is definitely going to be a big part of that. I mean, it's obviously not great in terms of the level of granularity when you get down to is any contact for back pain or osteoarthritis, but yeah, still just pulling what information we have together and presenting it alongside the other information. So yeah, there's a lot more to come over the coming weeks and months.
The other thing to say as well is that although the model hospital, model health system is a platform, we can link to other things. So we could link to, if people have got better drill down dashboards for their particular areas that we can link through, then completely not precious about holding it for the model health system. So if you have ideas that, or well, actually, if you have ideas that we could link off to other things and make it useful, or if you have your own products that you want to link in, then please speak to us. What I would really like is for a complete ecosystem where people can go in, you know, find an area, go, oh, that's interesting, where can I drill down, drill further, and if we don't have the functionality ourselves but other people do, then let's use that. Completely not pressured about that. So yeah, that'd be good.
Thanks, Jim. I see there's also another question on children's, which has been mentioned a few times. So yeah, we do have some of the information that's broken down for children, and within the Rightcare work, we've got a maternity and early years pathway as well. So that'll be one of the areas that's coming into that. So I see the document there is mentioning obesity rates and infant mortality. So yeah, those and vaccines, that's all data that's within that pathway that we've got. And also, yeah, we're doing some work on health inequalities as well. So that's something that we'll be bringing into this platform as well in due course. But as Jim said, yeah, any sort of specific requests or something that you think is particularly useful to bring in, then yeah, please let us know, and we can we can try and make that happen.
I mean, ultimately, if there are things that all of you are doing routinely, time and time again, that we could do once and help all of you time, then let us know. Let's just build it.
Okay, I think we've got a hand up as well.
It's Advait from Leicestershire, STP. Thank you for responding to the children's point. We're a bit of a poor relation in the adults world, and it's just kind of to say that even if potentially, I mean, I appreciate the feedback on that you're doing some work on that. So really, thanks for keep us in the loop on that, on the children's aspect. But even if it's possible potentially to, you know, where there's adults, you know, source data that's been used, for example, maybe we could just do a cut by age, for example. I know it's not as simple as that sometimes, but you know, just some sort of ability to kind of look at younger people in a different would be good.
Yeah, that's certainly something we can do. I mean, we've actually had a request through from the Northwest system, have given us a list of indicators that have been in the various packs of epilepsy admissions for children and asthma, etc. So
absolutely.
So yeah, we're currently just sort of pulling together what indicators we have. So yeah, we can certainly share that list with you and sort of get your feedback.
That would be great, please. That would really value that. I could speak to our children's leads here, and happy to kind of contribute to this development. It's wonderful work that you're doing.
So yeah, if you either pop your email address in the chat or just go via Alex, then yeah, I'll definitely link in with you on that.
Really good to get in touch with you on that, because we've just been working on, David in my team, who I think is on the call, has been working on a children's needs assessment for the region. We've kind of brought together all of that Rightcare data, some of it we can do down to CCG level and below, and actually, exactly as you said, if you want to do kind of a custom cut of some indicators, we can run those for you in the region. And if it's useful, and if it looks like it's a worthwhile thing, we'll feed it up to Bryn and Jim, and we'll put it on the system.
So yeah, massive help. Thank you. And Kate, my colleague, a colleague from LLR's on here from MLCSU, and we can both link in. It would be fantastic. Thank you. Thanks very much.
Okay, I'm not sure if I've missed some questions. Please shout. I can see one from Ian and one from Matt. So Matt, inequalities data, we don't have any in at the moment, I don't think, Jim, but we are doing some work so with the health inequalities team. So we've got the ambulatory care sensitive conditions indicator. We've got that on the we've got the inequality of gradient on that, but we're also doing some work with the inequalities team to look at a range of other indicators that we might want to do a similar cut of. So yeah, again, I know I keep saying coming soon, but yeah, that's something that we'll be able to drop onto the system hopefully in the next couple of months.
And also it depends sort of what you mean by inequality. I think I know what you mean, but there are sort of other bits of inequality data that we're looking at. So in terms of sort of board diversity and those sort of things that we're also adding, but I don't think that's what you're asking. But there are some other inequality bits we're looking at.
Great. And sorry, can't find Ian's question now. Yeah, Ian. So I mean, I think that's sort of in progress, but yeah, very happy to sort of link up with you on that. And yeah, sort of, I think you're on the alpha testing list anyway. So yeah, we can definitely link in with you on that. But yeah, if there's anything sort of particular that you want us to say now, then please feel free.
It was just really that was just giving an example, Bryn. But it's a kind of a Rightcare delivery partner. We tended not just to look at the Rightcare packs, but also look at some of the other data that was available to us through Model Hospital, GIRFT, and through Fingertips. So what would be really good is if we could just have something that you can kind of go to that gives you that helicopter view of things in the world. Because you reflected earlier about our A&E attendances or non-elective admissions higher for this system than another. But actually what we'd want to do is be able to see, well, is that a result of the fact that this system doesn't have as robust community services or robust primary care services in place as other systems we're comparing it might have. So it's just being able to have that kind of helicopter view.
And just adding to that, Ian, actually, I think that sort of takes it further from sort of just a benchmarking tool to a bit of analytics and a bit of sort of interaction. So A&E stuff, what about the population? So, Nottingham being a mining community with COPD patients and things like that coming in, are the admissions through to A&E normal as expected based on the population? And can we show those sort of things? And could we do a bit of modelling around that so to make the tool a bit more interactive? Really keen on any ideas around that sort of thing.
Yeah, absolutely, Jim. And there are many different kind of areas. I could pick Staffordshire as kind of some mining and some pottery kind of things where you might expect higher respiratory admissions because of the kind of past manufacturing industry. So completely agree, happy to support.
Great, thanks, Ian. Okay, so yeah, is there anything anyone else would like us to cover, or would you like to get 15 minutes of your day back? Sounds like the latter from the silence.
Is it worth just bringing up the list of compartments just in case that triggers anybody's questions?
Yeah, sure.
Give people 30 seconds to think and check before we say our thank yous.
The other question I had, Alex, was if people have found this useful, shall we do this again, and how often?
Well, I was amazed by very impressed by the excitement to have this. I know you've got your masterclasses and various introductions already on your newsletter and things, haven't you? So I wonder whether it's worth us doing our own one for the region. Potentially, as things develop, that'd probably be appreciated. Or whether you want to kind of manage this as your general regular updates. I think people will be keen to come along. So up to you, Jim. I'm not sure how this really fits into your plans.
Well, Midlands is my region, so I'm happy to do special Midlands stuff, but it's not just Midlands that have joined us, but more than happy to do this. If this is helpful above and beyond what we are already sending out and sort of webinars, then let's do it and let's make
I think it really has. I think kind of we sent it out probably by a different route from some of the other briefings and invites as well, which has probably got a bit of a different audience, which is great. And yeah, we've got a few things we want to try and do in a similar way in other tools. So absolutely, yes, really useful, I think, and yeah, really grateful. And yes, I'm really excited to see all the new things that are coming on, like how do we access this data at regional level and things like that. So yes, Ian, did you want to ask a question or say anything else?
No, it was just based on that conversation. I've found this really helpful. Would appreciate having other regular kind of updates as you're updating the system. One of the reasons being some of the Rightcare data that's now being shown on Model Health System is different to how Rightcare data has been presented in the past. So it's also useful to kind of have the opportunity to talk through that and understand it a bit better.
I think one thing I'd really like to try with this kind of approach is to pick a system and a program area and try and almost build a storyboard collectively and think, what would we pick out? What would the data be? And just have that kind of hackaday approach that we had before, Jim, where we kind of talked about how all these different data sets come together and think what else you'd throw in there and how it all become useful. So potentially, if people are excited, if a few colleagues from Leicester on, we could probably try that.
Totally. And I think this is a group that I don't think we interact with it enough. So we have a group of ambassadors, and I suppose that's a question. People want to be joined into that, which tend to be from provider organisations, and we give them sort of early sight on things and test stuff out. But actually, just going through this meeting, I thought actually that the communication and sort of your comments are probably as much, if not more, useful than what we get back from other people. So if people actually want to be involved in that ambassador program, then please get in touch. So in fact, did I put my email address earlier? I can't remember if I did.
I will send down a follow-up email then with contact details, invitation to the ambassador program, notes about what's coming up in terms of the new preview version. If there's anything you want to share on that one, and we'll set up a follow-up date for about 3 or 4 weeks' time.
Yeah,
if that makes sense.
Because basically, in terms of the ambassadors network, we're going to be going out to them probably on the 15th with the latest Plix data, our annual refresh, as an alpha test to people, and it would be good to get feedback from other people, not just the providers. So yeah, the more the merrier. And I mean that.
Wonderful. Right, we've got some good enthusiastic customers. Is there a last chance for any questions? Anyone wants to raise a hand? If not, thank you very much. Oh, where was that one? Joe, Regional Improvement Team, I was to talk directly to the ambassadors. Yeah, that's actually, do we know who all the ambassadors are, and are we allowed to get in touch with them in our region? That might be a good question to take away and find out about.
Potentially.
No.
GDPR, I'm not quite sure, but I will find out for you.
Oh, I only cover your personal life, not your work.
Alex, I asked the question because we've been told no in the past, or recently. It didn't used to be the case, but recently we've been told we can't go to them directly or have contact details or anything because of GDPR. But obviously, when you consent people, providing you consent them to allow that, then it shouldn't be a problem.
Yeah. Okay.
It just, I mean, it doesn't make sense for us to have our own group of contacts. To me, I don't want to duplicate. That doesn't make any sense. But equally, if you have to go through a third person every time you want to speak to somebody, it can become a bit of a problem in terms of timescales and stuff.
I mean, presumably we can invite all the ambassadors to the same session and then
just reply to all. Very good idea, Bryn. Thank you. That was really useful. Lots of appreciation on the chat. Bryn, really good detailed and clear explanation, and thank you for battling through all the sharing and technical problems. I know this is not always easy, and yeah, I think everyone appreciates it. So thank you very much. And you managed to keep 50 people for 2 hours looking at a screen. So only a few people dropped off. So really good job. So thanks all.
Well, back to you, Alex. Thanks very much for organising and getting people involved. So
very much easier on my part. Thank you. All right. Thank you all. I'll let you have your afternoons back. And thank you. Thanks for coming.
Cheers.
Yeah. Thanks, everyone. Bye.
Bye.
Thank you. Bye.